Hello everyone, this is Chadi Alraies from New York AVS 2024. I'm privileged to be with Dr. Lawrence Garcia, who have multiple talks, but today we're going to focus on atherectomy devices for endovascular intervention. Dr. Garcia, thanks for being with us.
No, thank you. It's great, and thanks to everybody, all the organizers of the meeting for inviting me. It's a great meeting. The new venue is fantastic and very well attended, which is fantastic
Absolutely.
to see.
Yeah, I was told close to 900 people showed up.
Yeah,
which is great.
Really
yeah.
great.
Yeah.
And you know, all things considered, New York's a perfect venue, and having moved from Boston, this is I love it. I love it, and the opportunity down here is fantastic.
Absolutely, it's faster.
Yeah.
So atherectomy. I mean, there's a lot in the toolbox, multiple options we have now, luckily, but we're going to learn from you which device to which lesion and what to watch for.
Yeah, so you know, it was a good session today in the sense that atherectomy, which is high on the hog, if you will, in regards to how we treat peripheral vascular disease, and it's mostly driven, almost exclusively driven by the need for vessel preparation in anticipation of some other adjunctive therapy. The adjunctive therapy that's most interesting for a lot of peripheralists is drug-coated balloon. And one of the key elements in the impediment, whether it's stenting or with just plain old drug-coated balloon or DCB, has been the impediment of calcium and recalcitrant lesions. So there was a huge growth industry for 25 years of atherectomy, with the atherectomy goal being dilatation of the artery. So changing of arterial compliance so that you could then perform what you wanted to get an open artery and establish flow and limit patient symptoms. And so if you look back at the earliest days, atherectomy was almost exclusively, back in the day, atheroablative. We had laser, and that laser had its real approval for limb salvage through the Lacey trial. That was good, but the FDA approved it only because it was the only metric that they had at the time, and it was all for limb salvage. If you fast forward a few years, in the early 2000s, directional atherectomy came along, and at the time it was called Silverhawk, and Silverhawk produced several trials, all registries, but the benefit was that you could debulk an artery to allow dilatation of the artery, and then at that time it was mostly balloon angioplasty with limitation of stenting. There were a lot of us that believed at the time, and still do, that your SFA is just a challenged artery to work in. It does a lot of gymnastics. We're sitting here right now, and so it's bent and torsed. But when you walk, there's a lot of activity to it. And so stents, generally, at least back in the day, didn't perform well there. Now we have newer stents which perform better, but not 100% better. And so the idea of doing something to leave nothing behind was really our goal. And as that grew, despite being registry data, the opportunity to then marry that technology to something better, not stenting, but rather drug-coated balloons, that was the combination. And it's been studied for trials that I helped lead, Definitive LE. I was involved with all the definitive trials, and then eventually reality came along from the Viva group. Long, calcified, really ugly arteries with directional atherectomy to debulk, change arterial compliance, and lay down drug-coated balloon and have a primary patency that was in the mid-70s on a 20-centimeter ugly set of arteries is a remarkable outcome. Other devices then came at the same time. You have orbital atherectomy, which was led by many trials, a lot of them small registries, but one of the biggest core lab adjudicated trials was Liberty. And Liberty looked at patients with just simple claudication to patients with rest pain, Rutherford's 4 and 5. And then they, to their credit, they separated out Rutherford Becker 6, so the worst of the worst patients. And they looked at orbital atherectomy as a registry, followed by balloon angioplasty. And they have primary patency for the claudicant group, which is very similar to what Definitive showed back in the day, in the mid-80s, for about an 8-centimeter metric. But what was most interesting is that the major adverse limb events are male in Rutherford's 4 and 5, and importantly 6, were very low. In other words, you actually benefited the patient to go through the atherectomy and angioplasty. Then, you had another rotational device called Jetstream, back in the day called Pathway, and so they have a registry that Bill Gray and I helped lead, and at that time we found that you could do atherectomy in a drill format, kind of like rotational atherectomy, but not orbital. And you could get an outcome that's quite good. But if it didn't have the residual stenosis you want, which was about 30% or less, and you stented it, which was about 38% of the time, the stented group, with the change in arterial compliance, the stented group performed just as well as if you got very good debulking and just did balloon angioplasty. And so you have now 4 major devices. There's now 6 on the market, but 4 major devices which have gone through a lot of good registry data to support the outcome. Fast forward to about 8 years ago now, and because atherectomy, and this is what Dr. Zeller and I talked about today, because atherectomy comes at a price, it's an expensive device, and it also requires, because when you start manipulating an artery with things that debulk, you can throw embolization and have complications with either dissection or perforation downstream. Then distal protection devices add to the cost and so forth. And so about 8 years ago, a company came along that was in situ balloon technology that would send out a wavelet of high pressure. It's called shock wave. And so intravascular lithoplasty, or IVL, was born. And they've gone through several trials, and up till basically in 2022, when they published their PAD-3 data, they found that the combination of lithoplasty plus drug-coated balloon performed not only well, but better than if you just did DCB or PTA alone plus DCB. And so that was a randomized trial, and their complication rates were actually quite low. So now you have a whole series, a myriad of device companies which allow you to change arterial compliance in a way that allows you to then deliver drug. And they all work. At the end of the day, it's what do you choose and what's your risk aversion, right? And if there's a big calcific burden and you're going to start muckering around in an artery, you want to do it with distal protection. IVL has come along and said you may not need distal protection, but again, it may not be the panacea of working on all arteries. And so becoming facile with a whole series of different devices is very useful. And I'll just leave it with the last thing about IVL, which is interesting, is that all other devices that we use when it comes to atherectomy, not one of them tells you that you've succeeded in arterial compliance. But with IVL, since it's a balloon technology, you can actually see the restraining and constraint of the balloon melt away as it cracks the calcium. So that does kind of, in a visual format, tell you that you've changed arterial compliance. So in that way, it's also quite useful.
Yeah, and there's some studies from the shockwave. I'm not sure if above or below the knee, if you can remind me, is about the recoil.
Correct. And so that was below the knee, and with balloon expansion as well as with CSI, my colleague Dr. Mustafa showed this, that just with plain old balloon angioplasty, within about 5 to 10 minutes, the recoil is quite significant. And you got to think about it, right? The smaller arteries in your tibials, 3, 4, 5 millimeters at best, approximately, 2 to 3 millimeters distally. It doesn't take a lot to have a significant amount of recoil. And so changing the arterial compliance is a fairly useful way to maintain it, meaning getting bigger is better, but also durability. And so the challenge is that when it comes to below the knee, we didn't talk about this today, but below the knee, no data has ever supported the predicate of using atherectomy to get a balloon angioplasty result. And the reason is that no device besides angioplasty back in the day has ever been shown to be beneficial than simple angioplasty.
But some people do it.
Some people do it. So not until recently, this is off the topic, but not until recently did, when Abbott came through with the Life BTK trial, that was our first real victory when it came to a scaffold or an implant for below knee to actually be not only successful acutely, but then in long-term durability. You know, you have other things. You have the TAC, which works, and TOBA BTK, but again, that's for short segment dissections. This was for more longer lesions in the Life BTK, I mean, and the outcomes there were remarkable, and the FDA approved it, mostly driven by its primary patency, which is a huge success for our field.
That's great. I mean, that's cannot be any better. I never interview somebody about atherectomy or any device overview like this, Dr. Garcia. It's an amazing interview, overview.
I'm very passionate about atherectomy, I think vascular disease is one of those things that is remarkable because as a cardiologist, if you don't look for it, you won't find it. But anybody who has vascular disease has heart disease, and the exact opposite is true. Everybody with coronary disease has vascular disease.
Absolutely. One of them will start the process.
Precisely.
Thank you so much, Garcia, for your time and a great overview of atherectomy devices. Again, on some touchdown bonuses on below knee
yes, sir.
therapies. Watch these videos and others on the New York AVS YouTube channel. This is Chadi Alraies coming to you from New York in 2024. Thank you very much.
Thank you.
Thank you.